hold out for the book and not watch these new seasons, but I'll see how long I actually last with that. Probably like a week. We'll see. Okay. Since I recorded that, that's great. Okay, so toxicology is I think it's kind of a fun topic. There's a lot of stuff about poisonings that I don't know why I find that interesting. I just do. It's not something I'd ever want to do as a career, but as a passing interest, it's sort of fun. So anyway, this isn't a super serious lecture, but there are some, of course, serious consequences to overdoses. But we'll cover a number of things. The first thing I want to say, and that I'll just give the caveat that if you know this number by heart, it might benefit you in some capacity. Just leave it like that. In your life, right? So Poison Help, 1-800-222-1222. This is a number that you should always know. In any practice environment, I think it could possibly come in handy, but especially if you work in like an urgent care or ED for sure, have this number memorized. And the nice thing about this number is it works anywhere in the country, and it will direct you to a regional poison center. So like Minneapolis Poison Center is at Hennepin County, and they cover several states within the area, so it's not just like Minneapolis. I don't know where the other closest one is. I'm guessing Chicago has one, but I know they take a lot of calls from like the rural areas, like the Dakotas and stuff like that too. Poison centers are always like one of those line items in government spending. Like, oh, we need to cut the poison center. No, don't cut the poison center. I'm not a huge fan of like excessive government spending, as most people probably aren't, but why waste money on something that doesn't work? The poison center actually is valuable service, I think. And they can take calls from anybody at any time for any real reason, and you can get a hold of somebody actually quite quickly. There's a special line for healthcare providers too, so you can get to somebody who's maybe more advanced. So like the nice thing about Minnesota is we have a different system than a lot of states or a lot of centers will use nurses. Not that nurses aren't well trained, but we actually have PharmDs and especially clinically trained toxicologists that staff our poison center. And so you'll actually talk to somebody who's a little bit higher trained than the average person that you probably find at a regional poison center. They do have pharmacy interns that might take some of the lower level calls, so that's where a lot of times the differentiation gets you from like healthcare provider to just maybe the standard call coming in. So with that in mind, just keep the poison center in mind, and they do get funding based on like their volumes of calls. So if you have any overdose and you even want to run it by somebody to check your plan, I would recommend just calling them. They'll also follow up and do monitoring. So like let's say you're in the ED and you call them and talk to them about your plan, they'll follow up with the floor once the patient transfers and talk to that nurse too. So they provide some continuity of care that way. All right, enough plugging for the poison center. So the world is full of toxic things, drugs being one of them, but I've got some other fun things on here. That's the Brazilian wandering spider, which is supposed to be like one of the most poisonous spiders in the world. The black mamba is not the most poisonous snake in the world, but it's one of the most deadly because its poison kills quite quickly, and it's very aggressive too. Digitalis foxglove, or foxglove, aka digitalis, which actually grows native in Minnesota sometimes. And I can't remember what type of mushroom that is, but it's a bad one. Take my word for it. We'll talk about mushrooms more in a second. I think it's an Amanita species, but I can't remember exactly what it is. It looks like a white mushroom. Moral of the story, don't just eat random white mushrooms. We had a resident who, he did his internship at the Poison Center, and he showed me a picture. He was walking down like a sidewalk in Minneapolis, and it was one of those Amanita, it's some sort of Amanita species, and it's a super deadly mushroom just growing out of a sidewalk crack in Minneapolis. So again, even if you get really hungry, make sure you're checking, make sure those are actually truffles before you decide to fry them up. This book is the Colson Book, and they come out with periodic editions just like any book. It's actually a pretty decent reference if you're ever going to go into tox or do work with a lot of tox cases. It's probably not a bad thing to have. It's actually just kind of cool if you do travel medicine or something like that. It talks about a lot of like poisonous bites and things. Just some good information. But again, this is sort of like the Bible when it comes to toxicology. It tells you signs and symptoms to look for, tells you like time frame, possible antidotes, all types of things like that, what types of symptoms to expect from an overdose. And again, it's the Olson book. It's not a huge book. It's like a kind of semi-pocket sized, I would say. Okay, so what is toxicology? Well, there's this guy named Paracelsus who lived during that time period, and he was the father of toxicology, and he was famous for saying the dose makes the poison. Basically, the concept is that really toxic substances can be completely harmless unless you take enough of it. And then an ordinary substance can be toxic if you take a ton of it. So it's all about the dose is what the moral of the story is when it comes to toxicology. If you want to know just some standard LD50s, LD50 is the lethal dose, the dose it would take to kill about 50% of the general population if they consume this much. And so you can see some mg per kgs of certain things. You can see like sodium chloride's on there, so simple things like salt, and actually ethyl alcohol having a higher LD50 than salt. Nicotine is a 1 there. You can see some other weird things like botulinum toxin is one of the most toxic substances known to man. Very tiny amount wouldn't be needed to kill somebody. There's some dioxins, kind of like a form of digitalis. Rattlesnake venom. I can't remember exactly what curare is. It's some sort of, I can't remember if it's a mushroom toxin or something else. But anyway, black widow venom, etc. Nothing too crazy there. But we'll get more into the drugs here in a second. But just a review of like the terminology we're going to use. So with toxicology, you have a group of, or a practice, or a whatever you want to call it, a discipline that studies adverse effects from poisoning of people, animals, and other organisms. So we're going to be talking about people, of course. But what you'd expect to see from some sort of toxicologic poisoning is a change from the organism's normal state. So you're going to see some sort of symptoms. If somebody's not symptomatic, it's not necessarily poisoning. They could have overdosed on something but be asymptomatic, right? So you don't necessarily have that same, those two don't always go hand in hand. Depending on the active compound being present at the target site for a specific duration of time is going to lead you to these side effects. So if we're overstimulating receptors or blocking receptors for an extended period of time using certain medicines. Poisons. Poison is aka a toxicant, and it's just a term that's used for something that's capable of causing a harmful effect in a biologic system. And again, we talked about dose dependent. So that's always an important thing to think about when you're working up an overdose patient is how much did they take? What's the half-life of it? Kinetics, how does it distribute? Pathway of exposure, was it oral? Was it skin? Was it inhaled? Those things can all be, of course, important and can drastically change how you might treat something. Okay, so there's millions of drug overdoses per year in the U.S., and you get a lot of healthcare dollars with that. And in Minnesota Poison Center, they get about 65,000 calls a year. The mortality is relatively low, but admission rate's high, and a lot of times these patients, well, of course, there could be accidental or intentional overdoses, but intentional overdoses will usually require a psychiatric consult and workup, and those patients are probably going to be an inpatient psych admission if they get medically cleared. And then you have the small percentage of people that have medical symptoms that require extended hospitalizations for that treatment. The most common overdoses are by far and away from prescription drugs, leading to these different calls. So yeah, you get like kids taking stuff or whatever, drinking something accidentally, but most of them are prescription drug related overdoses. Age 35 to 45 or 54 is the largest age group, and the largest rate or percentage is age 18 to 20. Internationally, just in case you're curious, their drug overdoses are more prevalent in the UK and Scandinavia than in Eastern Europe, but who knows if that's reporting or documentation. Deaths are considered injuries, so if you look at like stats from US-based stats, they pool injury-related deaths in with motor vehicle, firearm, and poisoning. So these are all lumped together. So the point is that it's sometimes hard to tease out these specific data here, but there are some. This is a sort of an older graph that shows you how things are broken up basically by what people are overdosing on generally when it comes to drugs. You can see that standard pharmaceuticals, which is a huge group of things that makes up more than half of it, or about half of it. NHI publishes some information about drug overdoses specifically, so it looks like you've got different parameters here. So you got female and male. It's pretty stable. It goes up every year, unfortunately, and it seems to be going up at a little bit faster rate than it did like maybe a few years ago. And I just want to show you this from heroin and non-methadone synthetics. So this is any type of opiate. So you got heroin, and then you've got like an illicit oxycodone consumption, that type of stuff. And you can see that's just like exponentially going up. Right now, heroin is crazy popular, unfortunately, and the pill forms and stuff like the oxycodones and whatnot are definitely still chugging along too. So you have a huge percentage of overdoses just associated with opioids alone. All right. So if we look at common things, analgesics, which would include possibly opiates, you have sedatives, antipsychotics, antidepressants. Makes sense, right? Our psych populations are at high risk for overdose. So those medications are certainly things they have access to. And if they want to attempt suicide, they might just take whatever they have and hope that if they take enough, it might do the trick. similar to other countries. So globally, this is not all that different when we look at global statistics. Interestingly enough, there's just a fun fact. Apparently, in Israel, antibiotics are the most frequent overdose reported, which is really strange. How would you really overdose on an antibiotic? But go figure. All right, clinical clues. So there's a lot of mnemonics that toxicologists do, which drive me crazy. I hate mnemonics, with the exception of SLUT. That's like the only one I can remember, which is why I always talk about it. But there's a lot of mnemonics that make up these things, and I'll show you some anticholinergic ones which we already talked about, but I think they're kind of fun. But anyway, you have clinical clues to look at. So really, it's a review of systems type of a process, right? So I don't need to educate you on that. You learn about this in other classes. But these are some things that might lead you towards certain types of overdoses. So seizures, altered mental status might lead you towards a mood-altering substance like maybe some sort of psychiatric medication, benzodiazepine withdrawal, alcohol withdrawal with seizures, respiratory rates, depressed breathing rate, of course, could be opioid. It could be some other things, combined sedatives, combined hypnotics. Cardiovascular EKG abnormalities. We have QTC prolonging drugs that could be leading you down that direction if you saw like a really long QTC, or maybe T-waves, potassium overdose, something like that. Skin and mucous membranes, so cholinergic, anticholinergic medications primarily would be what we're looking at here. Vital signs, of course, hemodynamic instability, if you're looking at drugs that affect blood pressure, any type of hemodynamic changes. And ocular pupils can change, so you get pinpoint pupils with opioid overdose, for example. Odors is kind of weird. I mean, you'd have to know specifically what these are, but certain poisons can come across as almond or garlic or pear scented. I wouldn't really put too much thought about that because it's not necessarily associated with drugs. It's more like odd things that people like arsenic or something. It smells like, I can't remember if it's almonds or pears. It's one of those ones. Anyway, not too important. So some questions just to ask. So drugs taken to expose to. A lot of times these patients might be altered, so you don't necessarily get the best history. So what happens a lot of times is you get a patient who comes in and EMS goes to these people's houses and they grab whatever they can find. So they come in with like a garbage bag of medications. Might be empty, might be old prescriptions. Maybe they took it, maybe they didn't. It's really difficult to determine. And sometimes they give them all to me and say, can you count these and see if any of them are missing? And that's always my favorite, especially when there's tons of like narcotics and controlled substances in them. Like there's a lot of legal problems with this, but I will do what I'm asked. So you can abuse your pharmacist in that way if you have the fortunate access to a pharmacist. So that's kind of the first thing you'd think about with an overdose, or somebody who maybe texted a friend and said something suicidal related, and they probably took something, we just don't know what. So what did they have access to? What are their common medications? Was there anything in the room next to them, empty prescription bottles or whatnot? Are they with it? Are they enough to maybe tell you what they actually took? Most patients who come in at that point probably will tell you, or, you know, you get the occasional person who might lie about what they took as far as maybe trying to make it sound more serious than it actually is. We get that actually probably more often than the other way around. One-time ingestion, was it just one time? Was it like an accidental, oh, shoot, I took way too much of my medication? Or is it exposure over, you know, maybe I've been taking twice the daily limit of Tylenol for the last 3 weeks, something like that. Accidental or intentional, of course, that doesn't necessarily matter in the short term. We're still going to treat the patient's symptoms, but it would matter as to how you'd make your plan for future care and continuation of care. Decontamination efforts, we'll talk about that. We'll talk about emesis. Did the patient have some episode of emesis on the way in? Were there any pills seen in the emesis? Patient weight is really important too. Mg per kg is a lot of times like how toxicology is broken down. So they'll say, you know, mg per kg general, you know, tox limit. So if you take this much mg per kg, that's considered the toxic dose. So it's not like necessarily a flat dose, although sometimes it is too. So, but weight can be important. Current clinical picture, and again from the previous slide, we talked about some of that stuff. So tox patient's going to work up very standard to any type of patient. You're going to stabilize, obtain IVIO access, consider decontamination, which we'll talk about, options for that. Talk about some antidotes coming up here, and then you're really going to observe and consider whether an admission is appropriate or not. Screening tools, I want to talk about urine drug screens for a second. So this is what would be on a standard urine drug screen, these things. So some of it's kind of helpful. However, a lot of this false positives, and I'll show you a resource for that in a second. The funny thing about benzos is there's our staff toxicologist told me this. I actually didn't know this before, but CLAM stands for clonazepam, lorazepam, alprazolam, and midazolam. Again, mnemonics and toxicology, but all the pretty much most common. So you've got Klonopin, Ativan, and Xanax on there as not flagging for the UTOX. So really, what benzos are you taking if that flags? Valium, that's pretty much the only common one left. Maybe temazepam. There's not a lot left on there. Let me show you this Medscape article quick. Oops. See if I actually can get it. It always like doesn't load. Actually, I think if I Google it, it's better. Well, let me just try it. Where'd it go? That's gonna make me log in. So if you Google exactly what I just did, you get to this article. They periodically update this. I'm trying to find, there's like a table. There we go. So this table, and if you haven't ever used Medscape, they're a really nice resource. It's pretty reliable. They do have a login. I think their content's mostly free though. But anyway, you can see what false positives. So like, let's say you get a false flag for methadone. Well, somebody might have taken Benadryl. It's the point here is that UTOXs are not helpful in a lot of aspects. Where is another good one? What about ibuprofen? I feel like that one false positives. Here, ibuprofen. So ibuprofen will flag for methadone. Anything else ibuprofen flags for? Ibuprofen will flag for cannabinoids and barbiturates. So you get a medication like a lot of people take on a daily basis. So just again, UTOX sort of with a grain of salt. Doesn't mean you can't get it. It might be worth doing, especially if you're trying to narrow down what exactly somebody took. But in the short term, not all that helpful. Frequent false positives again, and controversial just about, like, I've heard some tox experts say, what is honestly the point of the UTOX? What are you really getting from it? And make sure that you have a rationale for why you're ordering a UTOX. And a lot of things just don't show up on it. So possibly could work to, I've heard, I don't know if this actually happens, but for example, like date rape type benzodiazepines that are really short acting, usually by the time they get a UTOX, the metabolites are gone. The drug's not in their system anymore. So if you're trying to test for benzos with that, probably aren't going to pick anything up. And so that actually, I think there's been cases where that's been used as against the victim potentially, saying, well, their urine drug screen was negative for benzodiazepines. So again, just be careful with how you use this and make sure you're actually using this for a legitimate reason. Blood tests. So every time we get anybody with a potential overdose, we're going to test for Tylenol and aspirin because of potential co-ingestions and combination products. Aspirin's not super common combo, but of course Tylenol is, and they're really easy tests to do. And it's sometimes aspirin has a bit more specific symptoms for their overdose, but Tylenol overdoses are very generic as far as their presentation. So to be able to get the level back and get it fast can rule things out, or cue you into what you need to treat. Other tests, there's a lot of other tests you can do. You can pretty much check a blood level for almost any medication you can think of. A lot of times these aren't quick though, and they're going to require a send out for your lab. So in the acute phase, it's not really all that helpful. Most of these other tests are designed to check for compliance or adherence, so we aren't usually looking for an acute response for them. That's why they, most labs won't have the capability to do them on demand. So we'll start with decontamination. So the moral of the story of decontamination is most ingestions don't require any type of decontamination. The risk of decontamination are significant and usually greatly outweigh any benefits. So you really have to understand what you're treating and what the risk is for not binding up some of the medication that's in the gut or removing medication that's in the gut. So the patient, first and foremost, needs to be conscious and able to protect their airway, which with a lot of your overdoses rules out most of your patients. So there's that right there. You could potentially intubate somebody and give like activated charcoal through a G-tube. It's done sometimes in certain specific overdoses, but it would be a really unusual situation. Gastric lavage is not recommended, or stomach pumping not recommended anymore. The problem is aspiration. That's the big risk we're looking at here. So when you aspirate either stomach contents or activated charcoal plus stomach contents, you can get really severe lung damage and really nasty pneumonias on top of whatever you're trying to treat. So again, that's the risk, and the benefit generally just doesn't outweigh it. I feel like I've been skipping my funny, weird videos lately, so we're going to watch this one. It's not too offensive. Oh, are you kidding me? Oh, they took it down finally. It was a Family Guy clip, and it violates copyright probably, so apparently YouTube finally got to it. But it was a Family Guy clip where they take syrup Epic and they all throw up. Anybody's ever seen that? Yeah, I know. All right, well, there's my chance, but sorry. It works every year. I didn't check it, though. My bad. But anyway, syrup of Ipecac, not recommended either. I remember growing up, my mom always used to have like a little thing of syrup of Ipecac, and I always wondered what it was, and I remember asking her, she's like, don't ever think about taking that, and made it really clear not to touch it. And but no, it's not something that's routinely done. We don't make people vomit. Sometimes people may throw up on their own, and that's okay. They might throw up whatever they ingested. And so we can try and stop that by giving some anti-nausea medications, but generally speaking, we try and avoid that if possible. Whole bowel irrigation is like taking a colonoscopy prep. And this would be for people who have ingested something that, an example of this might be like extended release capsules with like a gel coating might glob up in the GI tract and just take a long time to pass. So I've had people, I think I did this once, and it was a guy who took a ton of lithium capsules. And we didn't see his levels rise up, but he was talking to us and he admitted to it. And so we started getting, I think he didn't get through very much of the bowel prep. So the question is, how much are you actually going to get your patient to take down? Because they're drinking a ton of fluid, and it's this polyethylene glycol solution, which probably tastes kind of salty and gross. But, it is an option for those types of situations, things that are going to clump up together, or possibly materials that aren't bound by activated charcoal. So lithium is ionic, charcoal is carbon-based, so it's not gonna absorb an ionic or highly polar molecule like lithium carbonate. But yeah, that's whole bowel irrigation, would be unusual. So activated charcoal is our primary decontamination method if we're going to use anything, and timing is really key. You're looking at 1 to 2 hours post-ingestion. After that, probably not worth trying at all, even if the patient's fine. 1 gram per kilogram dose. So usually looking at trying to get somebody to consume between 25 to 100 grams of this stuff. It comes in big tubes like this, and it looks like this. So I couldn't find an actual picture, but what it is, it looks like a black slurry. It's really thick. Never actually tasted it, but I imagine it tastes kind of like dirt or burned dirt, whatever that might taste like. Think about grinding up a piece of charcoal, mixing it with water, and drinking it. Essentially what you've got here. So that compounds the problem of nausea and vomiting, right? So I think, and even if somebody looks great and they're fine, I would always give somebody a prophylactic dose of Zofran before giving this, just because that's not going to harm them unless their QTC is already prolonged. Even then, I would still probably give it. It's just something that's a nice preventative measure, possibly, from somebody throwing up nasty black stuff all over and into their lungs. What else is that? Some caveats with the timing thing. Delayed gastric absorption, potentially. So think anticholinergic medications. We had an interesting case a while ago in our ER where somebody took a bunch of Tylenol PM with Benadryl in it. And so what ended up happening is their GI tract didn't process it, and they didn't have any signs or symptoms really right away because it was such a slow delay. And then all of a sudden they were getting really sedated. Their Tylenol levels spiked like a day later, so it really delayed onset. And so that would be a case that's not necessarily routine, but Poison Center might say, well, if they're doing okay, you might consider it a little bit later. So those exceptions I would always defer to poison control or a toxicologist. If you have a toxicologist on staff, that's great. Most places don't. So just make sure you're consulting with an expert on that, just because, again, the risk generally is pretty high with this stuff. Bezors, that's a term for a bunch of stuff clumping together. So you take a whole bunch of tablets at once and they just stuck together. You might consider redosing the person. So every once in a while you'll see Q4 hours multi-dose activated charcoal. And sometimes when you get medications that enterohepatically recycle, remember that's where the metabolites or the drug compound gets excreted unchanged in the bile, and then you end up absorbing that back in later. And those drugs, carbamazepine specifically, phenobarbital, not real common medications, but could be toxic in an overdose. I have seen carbamazepine overdoses before on that. It's probably the most common one that would be a medication still used by a fair amount of people. And again, antiemetic, Zofran, is a great one to give somebody prophylactically. Don't use a sorbitol-containing product. A lot of these used to contain sorbitol, and the idea was it's a cathartic, so you stimulate the GI tract to help push the charcoal through more. It makes people a lot sicker, and it's not generally. There's actually been some cases where it's had actually pretty severe complications due to really nasty diarrhea followed by nausea and vomiting and aspiration of the contents. So we use non-sorbitol-containing products. I don't even know if they make a sorbitol-activated charcoal anymore, but we don't carry it. Okay. Charcoal is not recommended for any of the following things. Think about heavy metals, inorganic ions, alcohols. So somebody who chugged a whole bunch of windshield washer fluid, which generally has methanol in it, or what's the other one with propylene glycol in it? Antifreeze, thank you. Yes, antifreeze. Either one of those probably not going to absorb very well with activated charcoal. Somebody drank a whole bunch of acid, you have bigger problems than that probably to worry about. But yeah, you've got a number of things here. The big ones probably are iron and lithium as far as like actual things people are going to overdose on, and the alcohols. The rest of this stuff, like, you aren't going to decontaminate somebody for taking a ton of calcium. You're just going to say, don't do that again, probably, and move on with your life. Cholinergic poison. So, okay, any questions on decontamination or clarifications before I move on to the specific different types of poisonings?
I just emailed you the guy.
Oh. All right. Well, I'll pull it up at the break, and we can watch it. All right. Thanks. Okay. So I'll start with cholinergic. Cholinergic's really straightforward in the sense that it doesn't happen very much. So don't spend a ton of time on this because it's not a big overdose source. What you might see if you work rural is large-scale industrial farming-related accidents, which would be like insecticide or pesticide-related, and that stuff can be cholinergic and cause cholinergic toxicity. If we ever got chemical weapons attack, which rare, but I suppose it's remotely possible, you would have also cholinergic side effects for a lot of that stuff, like mustard gas or those types of things. There are muscarine-containing mushrooms. Most of the time when people eat these, they just get really sick. They don't really have like actual long-term side effects that are problematic. I've had a couple people come in eating mushrooms, and they found, again, don't eat mushrooms you just find randomly. But these people decided to, and they get really sick. They get like 24 hours of GI distress, and then it's fine usually. So most cholinergic-related mushrooms are okay. Not okay as far as like to eat, but it's not something you have to like admit to your ICU for. Symptoms, so cholinergic side effects, I think there's sludge, salivation, lacrimation, urination, defecation, diarrhea, miotic pupils, bradycardia, potentially diaphoresis, and again, not usually deadly unless you got like a large scale, like if somebody fell into a vat of pesticide, that's where you're concerned. A couple of mushrooms here and there, probably not a big deal. Treatments, you can use anticholinergic medication, so atropine, you can get small doses of it IV, see how it works. It's basically a pure anticholinergic medication. Pralidoxime is a specific acetylcholinesterase regenerator, and it's only used for these types of overdoses. I was cleaning out our pharmacy a while ago when we moved from one floor to the other, and I got assigned a shelf that had a bunch of weird stuff on it, and pralidoxime was one. It looked like it was a jar from the 80s, and all the powder in it was like hard as concrete. So I threw it away, so we don't have any pralidoxime at Abbott anymore, because I don't think anyone's ever used it or needed it. But in a rural setting, it's possible. They don't make any product that's like directly IV available, so you'd have to do some. We don't ever take powder, and unless it's like a sterile powder that we're reconstituting, but we don't take like powder from a shelf and a non-sterile component, mix it with some IV fluid, and give it to patients. That's just something we don't do. It's not sterile. It's not a proper process, and our facility is not capable of doing that. But in a pinch, that might be what you actually would have to do in a situation like this. So anyway, I've never actually heard of this happening. I'm not sure how common it is in rural areas and what types of precautions they take, but that would really be where you would see it, if at all. All right, anticholinergic. This is a toxidrome. I think it's the only toxidrome I'm actually going to give you. And it's got all these funny little sayings. So you got blind as a bat, hot as a hare, mad as a hatter, dry as a bone, red as a beet, bloated as a bladder, tacky, like tachycardia, as a polyester suit. So they're kind of easy to remember as opposed to just remembering a word and what they match up to. But patients are going to be really dry. They're going to be probably delirious. Usually, it depends. They could be delirious. They could be agitated. They could be sedated. You don't really know. Anticholinergic can be a mixed bag. Usually going to have tachycardia as well. Red, dry patients. So that's a big difference between anticholinergic and sympathomimetic. So like a cocaine overdose versus anticholinergic might be similar in how they present, but the cocaine is going to be, usually those people are going to be sweaty, where these people are going to be quite dry. Mucous membranes are dry. Some causes: tricyclic antidepressants, antihistamines, scopolamine patches, too many of them on old people especially, oxybutynin, like those types of drugs, the bladder medications, some muscle relaxants, a lot of antipsychotics. There's a ton of medications that are mildly anticholinergic, lots. And so usually we don't see issues with them. It's, if you took a bunch of them, you might see some of that, like Seroquel or quetiapine is a slightly anticholinergic antipsychotic. Not a big deal in standard dosing, but if you see an overdose on it, you might see that occasionally. Some plants that people might consume: deadly nightshade or Atropa belladonna, which is where atropine and belladonna come from. Fly agaric is this mushroom, which is actually quite deadly of a mushroom. It looks like the Mario Brothers one, right? It's kind of cool looking. That's Amanita muscararia. And again, you have mushrooms that do both. You have some mushrooms that have more of a cholinergic type poisoning and some that have an anticholinergic. And the anticholinergic ones, from what I understand, I've never seen a really deadly mushroom consumption, but those would be the ones to watch out for. Yeah.
Do the hypnotic mushrooms, like people?
Yeah, like the recreational drug ones. I don't know. I don't know what they would expect. I suppose if you did enough of them, you might get some side effects somewhere or the other. But yeah, it probably depends on what type. And I actually don't know what species of mushrooms people use for psychedelic purposes. So it's a good question. All right, treatments. Activated charcoal, possibly, specifically for early ingestions, and definitely for tricyclic antidepressants. We'll get to those in a second, but that's a really deadly overdose, and so you want to bind that up as soon as possible. Antihistamines, maybe, but most of this stuff you're probably just going to let it ride. It's not going to, from a drug perspective, probably aren't going to decontaminate them. It's just not deadly enough to matter. If they're agitated or having seizures, benzodiazepines are great. That's one of your tox bag of tools that you always want is Ativan or lorazepam. Works for pretty much any type of agitation. That's a go-to for agitated overdose patients and agitated drug users as well. Ice packs, if they're hyperthermic, you want to try and cool them down a little bit. Physostigmine is a IV acetylcholinesterase inhibitor. You could use it for a really severe case, but what I've actually seen it used for more is a diagnostic aid in small doses. So, like we had a patient who we thought maybe it was a Seroquel overdose. We gave them a little bit of IV physostigmine. She was delirious. She was acting weird. She was normal like within a minute. It was kind of crazy actually to watch it, and the toxicologist who's new to our staff was explaining it to me, and she's like, yeah, this is something I use for diagnostic just to rule out anticholinergic toxicity potentially in weird situations like this. So it's something you could use for diagnostics. I've never seen it used for an actual treatment though, so it's possible. Okay, acetaminophen. Acetaminophen is the most common associated poisoning for drugs when we talk about drug overdoses, both from accidental and intentional overdoses. It's most widely used analgesic worldwide, which makes sense as to why we're seeing so much of this. It comes in a lot of products, so you get brand, generic, you get all the combination products, max therapeutic dose, again, 4 grams a day, like you guys all know already. Generally, they think 150 mg per kg or about 7.5 grams is considered to be potentially toxic. So you don't have to go much higher, double your daily dose, max daily dose, and you're already there. Presentation is really variable. During the first 24 hours, it's not all that specific. People might have some elevated LFTs or INR elevation, because it might be if they took a lot, it's already affecting the liver. But if they didn't take a ton, it might just be maybe some GI upset. They might not have any symptoms at all. After 24 hours, if they do have some liver toxicity, which even if they take a small overdose, relatively small overdose, they're probably going to get some LFT increases. You're going to see about 24 to 48 hours, those continue to rise. They might get some right upper quadrant pain as well. 48 to 96 hours, you're looking at peak LFTs. And that's when your fulminant liver failure is possible. I should point that it's very rare to actually see somebody go to fulminant liver failure. However, we do treat these aggressively so people don't get to that point. And stage 4 would be up to 2 weeks, and that's when most patients will end up making a full recovery. The liver is resilient. It can take some damage, fortunately, and most patients will be fine. Less than 1% of overdoses will need to require transplant or will actually die from because of the overdose. So Tylenol, while it's a really common overdose, and yes, you can kill yourself with Tylenol, it's very hard to do it, actually. And because you can treat it even if you wait a couple days into it, you can still counteract some of the effects of it if you're giving it. And this would be something that we do activated charcoal for if somebody took a ton of it, just because we don't, again, want to progress down. We want to watch out for that 1% of people that will possibly end up in severe trouble with this. And a lot of the stats are because we treat this aggressively. We treat it with charcoal. We give acetylcysteine, which I'm going to talk about here in a second. This is, I just want to show you, these are real labs from a real live patient from a few years ago. What this is a 3-day lab, so what we're looking at is 3 days worth of data. And I'll point out the liver panel here. You can see that, and this is reverse chronological order, so most recent up top. But when they got admitted, you can see that's really high. That's some of the highest enzymes I've ever seen. So definitely significantly elevated. The other thing that's interesting is the INR. So remember that INR is a function of measuring your body's ability to clot, which is directly correlated with your active clotting factors. If you don't have good production of clotting factors, that correlates directly with liver function. So people who are end-stage cirrhosis patients are going to have usually baseline elevated INR because they just aren't producing very many clotting factors. In this case, you see this with hepatotoxicity. INR is actually a really good measure of direct liver function because of that. So while AST is okay too, it's going to show liver damage. INR will show you actually how functional your liver is versus how damaged it is. So you get both sides of the coin there. Elk phos, bilirubin can have some things too, but really we're looking at the enzymes and the INR. All right, so on these slides I have skulls, and 1 skull or 2 skull or no skulls. The more skulls, the more deadly. All right, so acetaminophen poisoning, again, I don't know if it really deserves a skull, but I got one. So non-specific, activated charcoal, and acetylcysteine. So let's talk about acetylcysteine a little bit here. Acetylcysteine, it's a hepatoprotective product. It restores hepatic glutathione. And what glutathione is it's the precursor or cofactor in metabolizing acetaminophen into a product that's safe for the kidneys to excrete. It's non-toxic. If you run out of glutathione, what happens is acetaminophen creates a secondary mediator called NAPQI, which then ends up binding to another thing and causing cell death ultimately. It becomes a hepatotoxic metabolic byproduct, if I'm looking at it that way. So your liver only has so much glutathione it can use, and eventually it's going to run out of it if you take too much Tylenol. So while this is fine for most people because you aren't going to run out of glutathione, in patients like this where you take too much, your liver just can't process it. It shunts it down an alternate pathway. You end up with toxicity. So acetylcysteine helps restore hepatic glutathione and also helps serve as a substitute and cofactor for that reaction. It enhances the non-toxic sulfate conjugation of acetaminophen, allowing you for safe pathway through the body to renal elimination. And that's really the gist of it. So the sooner you give it, the better chances you have of binding up that making sure that extra Tylenol is getting processed through the normal pathways versus going down the toxic pathways. This is the Rumack-Matthew nomogram. It's a very popular tool for Tylenol overdoses. And what it means is it's sort of I think it's a logarithmic scale, yeah. So what you've got here is plasma concentration of Tylenol. And depending on when they've ingested it, you always start at 4 hours because before 4 hours, the distribution and absorption of Tylenol is iffy, and you can't predict it. So you could get, it's one of the biggest things that kind of bugs me. I get providers who are really excited about these, and they're like, oh, let's get a Tylenol level. It's been 2 hours since ingested. It's like, let's not, because you aren't going to be able to use it. And it'll come back and it'll be really elevated or something. It's like, well, or it's not elevated, and then you blow it off. Just wait until 4 hours. Again, I don't know why. I've tried to talk people out of it, but they still do it. They don't listen to me. But at the end of the day, based on the literature, you can't really use that 2 hour level for anything. So wait until so even if you decide I want a 2 hour level because I really want to know if they took a bunch of Tylenol and how severe we're looking at. Well, okay, but we still have to get the 4-hour level. So you get your 4-hour level. If you're below, if you're below your treatment line, you don't have to treat with anything. If you're in between, that's no man's land. It's like, well, you could or you couldn't. We don't really know. And the Rumac-Matthew is the dotted line, which is treat. So most people would say that if you're above the lower line, you would treat for most cases and most patients. But I've had patients who are really, really close to that line, but slightly under. And Poison Center always says not to do it. So I don't know what you could call that, but they do kind of treat this as a cut and dry black and white. So I've had some that are really close, like maybe 120 or something like that at the 4-hour mark, and they said no, don't treat them. Is what it is. And you can Google that and find it if you don't have it or can't find it in a reference. It's all over the internet. It's pretty easy to find that line and what the references are. Just make sure that the blood concentration matches what your lab's reporting, because some labs might report it differently than what the nomogram actually is showing you in different sites, especially if you're looking at like a European version of it. So acetylcysteine, when is it actually indicated? Well, if the serum acetaminophen concentration at 4 hours is above that treatment line, that's the obvious indication, right? If you suspect a single ingestion of greater than 7.5 grams or 150 mg per kg, whom the serum acetaminophen will not be available for more than 8 hours, that's somebody who you might want to treat empirically. So that would be a case where you can't get them to a lab, or your lab is malfunctioning or whatever. You can't get a level. If the patient with an unknown time of ingestion and serum concentration is greater than 10 mic per milliliter, that would be, or 66 micromoles per liter, whatever units your lab is using, that would be somebody who you would consider doing. Patient with history of APAP ingestion and severe liver injury. So if they took a ton of Tylenol, you don't know when, they come in and check the labs, liver enzymes are really elevated, you don't really care about the level at that point. You'd still get one to trend it, but at that point you're just going to treat them right off the bat. Patients with delayed presentation, so 24 hours after ingestion, liver injury, and history of excessive acetaminophen ingestion. So it's pretty much the same thing here. So again, those are kind of the criteria you'd look at for treating Tylenol overdoses. I have had some providers do it a little more aggressively, and when they don't necessarily meet this criteria, but they have history of a pretty decent ingestion, we're waiting for labs to come back, and they're like a teenager or a kid, say, let's just treat them right now. And again, there's some debate whether that's actually appropriate, but it's their choice, not mine. So, any questions on Tylenol poisonings? How we do that? It's pretty much N-acetylcysteine is the primary agent. The rest of the supportive care is nothing really. That's it. The treatment is a loading dose, then you follow it up. One thing I will just say about N-acetylcysteine is don't use oral. Oral is available and it is technically indicated, but IV has much better success rates with it. It also is a faster course than oral. Oral is like a 72-hour course. IV is 21 hours, and you don't have to swallow acetylcysteine, which supposedly tastes terrible. All right, salicylate poisoning. So aspirin, Pepto-Bismol, wintergreen oil, Bengay, Alka-Seltzer all have different types of salicylates in them. People will have an altered mental status, sweating, pulmonary edema. Oh, I got the aspirin mnemonic here, just for those who like mnemonics. Increased vitals, nausea. Basically, if you get really high levels, you're going to be looking at seizures potentially as a presentation. And then the altered mental status would be maybe acute. But this could be really a lot of things. It's not necessarily a hallmark aspirin overdose. Yes, if they had every single thing on there, but what patient's ever going to meet that perfectly? Activated charcoal will work for salicylates. Sodium bicarbonate can help with the alkalinization of the urine, so you increase the urine pH a little bit and help excrete some of the acid more. What else? Dialysis. So that's probably the big thing, that you can dialyze this off pretty easily. So if somebody has a severe overdose, you're probably just going to send them straight to dialysis. All right, we'll talk about TCAs and we'll take a quick break. Tricyclics. So Tricyclics is a double skull. This is a really nasty thing to overdose on. And we talked about this a little bit during depression, but you get sort of a couple different things going on. Anticholinergic toxidrome. People especially tend to have seizures on big overdoses of this. And then you get the CV toxicity, which is related to its antiarrhythmic effect. Prolonged QRS, prolonged QTC, branched bundle blocks, and then different types of dysrhythmias, possibly leading to a cardiac arrest. Onset's also usually going to be probably slightly delayed because of the fact that it's anticholinergic, so delayed absorption, delayed onset. Activated charcoal for sure if they meet the time frame. Bicarbonate can help can help with the QRS component potentially. It can also help with some of the possible pH. You could possibly be getting a little bit acidotic at that point too. And then for seizures, agitation, benzodiazepines are appropriate in these cases too. We don't use fosfomycin or phenytoin. Those also have some antiarrhythmic properties as well, and that's one of the reasons why we would combine those two. And then lipid rescue. So lipid rescue is a newer thing that I'm going to talk about a little bit during beta blocker overdoses in a couple slides, but the concept is you give a bunch of lipids and you possibly absorb whatever fat-soluble or fat lipophilic drug is circulating in the body and bind it up so that it can't access receptors that way. It's a last-ditch effort. It's not really proven in tricyclics, but as you can see by the slide, there's not much you can do with a tricyclic overdose. You can run a code on somebody and give them epinephrine and do ACLS, but you're not going to get them back. I mean, just to be honest with you, because you can't reverse this. You can't give an antidote. You can't do anything with it. So if you give them a whole bunch of lipids at once, I mean, if they're already in the point where they're arresting, you have very little options, so you might as well try it. So a lot of times when we have these unknown arrests or PEA where we don't know, maybe an unknown ingestion, we'll give a lipid bolus just because it might help the patient. You know, it's probably not going to hurt them at that point. So again, not just a really, really nasty overdose to deal with, which is why we don't prescribe them that much anymore, and why we want to be careful with patients who are unstable psychiatrically with these medications. But okay, we'll come back and pick up at psych in let's take 10 minutes. Come back at 4:30. All right, so anything that falls in the psych realm, like SSRIs, SNRIs, atypical antipsychotics, mood stabilizers, a lot of them are pretty safe-ish. I've got a couple exceptions down here. So if you take a ton of SSRI, nothing generally happens. People might be sedated, they might feel a little bit ill. With citalopram, you could see some QTc prolongation. Atypicals, again, you can see some anticholinergic effects potentially on some of them, but generally acutely, it's sedation is probably the biggest deal with those drugs. Possibly EPS or extrapyramidal symptoms, like movement disorders. Mood stabilizers, we talked about lithium specifically would probably be the one that's the most likely to cause issues, which is down here. So confusion, somnolence, seizures. So we can hydrate people and try and dilute it out, which is the easiest way to do in certain tiers. So basically, there's different blood concentrations you look at with lithium overdoses. Over a certain threshold, you send them right to dialysis. If it's under a certain threshold, you would either consider giving them fluids and supportive care, or if it's under a certain threshold but they're symptomatic, so if they're having tremors, that's specifically the first early signs of lithium toxicity, that would be something you would consider dialysis for right away too, because it might be building up at that point. And again, remember, activated charcoal doesn't work for lithium overdoses. Wellbutrin is a different caveat too. You have the possibility of causing seizures, specifically lowering the seizure threshold. So people who are already prone to seizures or an alcohol withdrawal or benzodiazepine withdrawal would be at high risk for seizure on Wellbutrin overdose. So Wellbutrin, I think for a long time we thought it was somewhat benign, but it's been something it's a really popular antidepressant, so people have been overdosing on it more and more, and sometimes they can be pretty nasty. So from the seizure standpoint anyway. What else? I feel like there's one other one that's not on here that I wanted to talk about, but valproic acid can be problematic in overdose. I think I mentioned that during the anti-epileptic drug lecture, so possibly as a mood stabilizer if it's used in this case. And you can get some liver damage, and we use levocarnitine for reversal agent of that. It's really rare. I've seen one case of it, and people for some reason don't tend to overdose on it that often. But just keep that one in the back of your head too, not for the test, but if you work in ED, that would be one to remember as one of the few psych medications you do have to be pretty concerned about if somebody overdoses on it. All right, opioids. Debating whether to have opioid 1 or 2 skulls certainly a very effective way to kill yourself, and it's certainly a popular choice to overdose on, but it's really, really easy to treat, which is nice, except for methadone. That's terrible to treat, but everything else is pretty good. Unfortunately, people aren't overdosing on methadone all that often compared to the other ones. So with opioids, you have your standard ones. Heroin, of course, is illicit, and the other ones being usually obtained illegally or taken because it's left over from the surgery or whatever. So if somebody does overdose on this, and even if they take a little bit too much, you can see some of these effects. So CNS depression, respiratory depression, bradycardia, and those being the biggest things that are going to kill somebody. So respiratory depression specifically going to be the severe effect here. With methadone, it does have QTC prolongation, so the overdose respiratory depression plus QTC can be really problematic because you can't really reverse the QTC portion of it with naloxone, and you can end up with a cardiac arrest. So treatments, activated charcoal if indicated. So if somebody took a bunch of oxycodone and they're in your ER and it's been an hour, they're probably sedated and probably aren't going to qualify, but they might not be, so you never know. You could try it. And then there's Narcan. So I actually think we've had some cases where they've recommended not even doing activated charcoal for opioid overdoses and even Tylenol overdoses too, because Poison Center I don't think likes it very much. I think they've seen too many cases or heard of too many cases of aspiration, and they just don't think of the benefits there, and maybe the data supports that. I'm not exactly sure. But the point is that if there's a really good antidote for something, and in that case, acetaminophen, you have acetylcysteine works quite well, especially if given early, and naloxone, which also works quite well. What's the point in reversing somebody if you can just medically manage them pretty easily? If you're keeping an eye on them, it's not that difficult to do it. Certainly, once you get to a point with an opioid overdose with respiratory depression, you can be so apneic that you either can't get back or you end up going into cardiac arrest, and that's a different story. But for an early overdose or somebody who's still a little bit conscious, it's pretty easy to bring them back with Narcan, and it works very quickly. So usually the dose, I'm not concerned you know the dose for the test, but usually going to do anything from 0.4 to 2 milligrams. It's a pretty decent range of dosing with Narcan. And I think unless your patient's dying actively, you could start pretty low with Narcan. Problem is people get really agitated when you take away their high. So if you give somebody a huge bolus of naloxone without really considering the consequences, you could end up with a nurse taking a punch to the face or something like that. So just be a little bit careful with it. And again, if your patient's passed out and you're going to have to intubate them, you can definitely slam it in. But just keep that in mind that side effect's definitely possible. Narcan doesn't have a very long half-life, and I think I said this during the opioid lecture, but most opioids have a longer half-life than naloxone. Naloxone's got a couple-hour half-life. Heroin's got like a 4 to 5 hour half-life. So it's not going to last the whole time the drug's on board. So continuous infusions are usually needed for large overdoses and can definitely be started. So if somebody responds well to naloxone, but they kind of are starting to get sleepy, maybe 20 minutes after they got their dose, starting to go back into that respiratory depression, looking apneic, you can start an infusion on them and just titrate it to effect. IV sodium bicarbonate, if they have acute RS prolongation, which would be super rare, you could try that. Kind of the moral of the story with tox, if you're picking up on this, is that agitation, we like benzos, and cardiac side effects, we like sodium bicarbonate. But a lot of this stuff, unless there's a direct antidote like naloxone, it's a lot of symptom management. So in this case, we have a naloxone antidote. So bicarb would be maybe for a methadone overdose, but in that case, the question of how effective that would be debatable, I think. So pathomimetic, I didn't put any skulls on. It's not a super deadly overdose. Cocaine maybe with cardiac arrest in rare cases, but the rest of this it's not. Methamphetamine, people are super agitated, yes, and they're maybe annoying and maybe dangerous to themselves and other people, but they aren't going to die usually from the drug itself. So you have a number of things. They might kill themselves or do something really, impulsive on them. That's different, but the drug specifically and reversing the drug once they're in a controlled environment, not really super big deal. You could do activated charcoal for an ingestion. The question would be the utility of that. I don't know a case where you'd consider that. Maybe if somebody took a ton of their over-the-counter Adderall, poison control might recommend that, especially in a kid. I don't know, but it'd be an unusual situation where you'd want to do it, but you could use it if you needed to. It would work for that medication. Agitation is going to be again our favorite toolkit drug, lorazepam in most cases, or benzodiazepines. Wide complex tachycardia would be sodium bicarbonate. If the patient's hot, cool them down. Very similar to our anticholinergic treatment. And then antihypertensive. So remember, forget about your alpha receptors. So we like to block phentolamine. Phentolamine will block alpha receptors, and then you're usually going to add a beta blocker. Nice thing is, if you block the alpha receptors, you can possibly shunt to the beta receptors, but you can watch for tachycardia pretty easily. If they're already tachy, probably want a beta blocker on board anyway. But if you block both sides, you can manage the hypertension nicely without having to overtax one of the things. So usually we're looking at a balanced approach here. So labetalol, there's some studies that show that labetalol alone might be okay, but it's debatable, and I wouldn't necessarily recommend it. But it does have some alpha activity, so you could consider using it. Some alpha blocking activity, I should say. Chest pain related to cocaine overdose, nitroglycerin can be helpful. And in really severe cases, you could use nitroprusside as a broad spectrum vasodilator to help open things up and get the pressure down. But, usually, I mean, these you don't see. You might see chest pain, probably with a cocaine overdose, but mostly when it comes to like other methamphetamine overdoses and stuff like that, probably looking at more of a psychiatric management and more of a psych emergency management situation versus an actual like toxicology case. So, I don't think I've ever seen a caffeine overdose in the ER, but I suppose it could happen. I think it's pretty dangerous for kids, especially if they get their hands on like some sort of powdered caffeine product, but I haven't seen one personally. Sedative hypnotic, also not something we're really concerned about in overdose. Benzos, when taken by themselves, it's very difficult to cause any severe damage. Some respiratory depression is going to be happening, possibly, but likely you're just going to have pretty severe sedation on them, which could mean that the patient's just not breathing enough to keep their O2 sats up, but it's not like the level you would see with an opioid. Now, if it's combined with an opioid, sure, combined with alcohol, possibly, but for the most part, you've got a relatively safe drug when we're talking about all these in comparison. So treatment, supportive care, usually just let them sleep it off. We'll almost never need activated charcoal. I would almost never recommend it unless you knew it was a co-ingestion or something, maybe. Again, most likely combination. So like Heath Ledger overdosed on a number of medications, several of which were benzodiazepines, but he also had alcohol and opioids in his system. So you need co-ingestions to really actually kill somebody with sedative hypnotics. Sometimes we get people who take a bunch of Ambien like during the day, or accidentally take an Ambien during the day, and you're like, what's wrong with this person? Did they overdose on something? No, they just accidentally took a sleeper during the day, and they just are really out of it. An overdose on sleep medications likely not gonna, again, sedation really is all you're looking at there. All right, beta blocker and calcium channel blocker poisonings are very similar. There's some subtle differences though. They're both super deadly. I'd put them in the same category as your Tricyclics. There's a little bit more we can do for these, fortunately, though, than Tricyclics. So any beta blocker would qualify for this. So anything, metoprolol, propranolol, whatever. Symptoms, hypotension, bradycardia, of course. You'd expect that from taking more of the drug. What's going to happen is you get prolonged PR interval, QRS prolongation, and ultimately the myocardial cells just can't do much, and you end up with sort of a cardiac arrest situation. Basically, you end up going into arrhythmia. Mild hyperkalemia potentially, and usually these patients have hypo or euglycemic, whereas calcium channel blockers are usually hyperglycemic. So that's a big diagnostic difference, and that has to do with there are some calcium channels in the pancreas, and so blocking them, taking a big overdose can also cause some carryover there, which can affect insulin release and production. So you get a bit of a transient hyperglycemia going on. Treatments. So for beta blockers, activated charcoal would certainly be something we'd want to do. And this is something you'd want to do as soon as possible. And if the patient's with it, even if they're pushing that 2-hour window, it's probably still something we're going to try. Fluids can help with hypotension. Atropine can help with bradycardia and boluses. But for the most part, you're going to be focusing on the bolded therapy, which is high-dose insulin. And I'm going to talk about the rationale behind this in a second here. So we'll get to the mechanism, or the proposed mechanism anyway. But it's really a lot of medication. So 1 unit per kilo IV bolus, which is a lot of insulin. So you're giving somebody like 100 units potentially IV, which would put a lot of people into a pretty significant hypoglycemic symptom. So we give dextrose. Most of these patients, again, are hypo or euglycemic, unless they're diabetic. IV glucagon is an alternate option. IV glucagon is difficult to make and administer due to the presentation of the products that are available. So high-dose insulin has more data behind it, and it's the more popular choice. It's really easy to compound a really high concentration insulin drip. And I think actually the pioneering studies for this were done at Regents Hospital. They did a lot of this in pig models. They do a lot of pig research at Regents, believe it or not. Pigs have kind of a similar cardiovascular system to humans. And that was a big area of research that they did, and that's a lot of the articles supporting this came out of regions initially, but it's pretty much been adapted. So Minnesota was one of the first places doing this. Now it's pretty much a nationwide standard that you do high-dose insulin therapy for these overdoses. IV calcium and sodium bicarbonate for membrane stabilization can help as supportive care. And then IV lipid emulsion potentially too would work for this. And some people will argue that actually maybe you should be bumping IV lipid emulsion up a bit. This isn't necessarily a flow chart, by the way. It's kind of like, well, where's your patient at? If the patient's just mildly hypotensive and getting bradycardic, maybe you're giving them activated charcoal, you're going to watch them, maybe it won't turn into a full-out overdose. Your pushing fluids, giving atropine. In that case, some people would argue, yes, this is the time to give lipids. You want to create that lipid sink in the body and absorb some of that fat-soluble beta blocker. So specifically, a drug like propranolol is highly lipid soluble, would respond pretty well to a beta blocker overdose. And the interesting thing about that is we use propranolol a lot in psych patients now as an anti-anxiolytic medication. So it is definitely should be on your radar as an overdose, as a common overdose. Most people who are your average person taking metoprolol probably aren't at high risk for overdose, but when you have a psych patient, it's different. So propranolol is definitely something we see from time to time, even though it's not really a common antihypertensive med. Calcium channel blocker, very similar. We're really focused here on diltiazem and verapamil, and that should make sense, right? They focus more centrally on the heart, whereas the other ones are peripherally acting. So yes, you could get some problems with a big amlodipine overdose, but it's not likely to be as fatal. So really, we're talking about these two drugs. Hypotension, bradycardia, prolonged PR, QRS prolongation, and again, that hyperglycemia is the big difference in diagnostics here. Treatments, activated charcoal will work. It is indicated if the patient meets the criteria. Same type of treatment, same high-dose insulin. Lipid boluses is not recommended for this because most diltiazem and verapamil aren't really lipid soluble. So you could do it. There's probably nothing wrong with it, especially if you had an arrest situation. But it's just the data and the theoretic mechanism behind it isn't as solid as with beta blockers. So. All right, so what is it with this insulin therapy? Basically, you end up with a positive inotropic effect from the insulin therapy. Why? Well, because of animal data mostly. But there's a lot of good case reports and cohort case studies coming out of all over the country from using this. So there's some decent literature out there now. Mechanism, beta blockers, calcium channel blockers interfere with myocyte metabolism. So beta blockers inhibit pancreatic glucagon release, which can reduce available glucose and diminish cardiac output and impair hepatic glycogen breakdown. So you have a lot of issues with how your body allows an energy resource, in this case glucose, to be available, and how your heart cells can actually use that glucose. So what this is supposed to be doing is providing some sort of a substrate for aerobic metabolism within the myocytes. So essentially, think about giving a whole bunch of insulin as you're really stimulating your body's ability to utilize glucose, and that's supposed to help with this whole process. But that's sort of the theoretical mechanism. You can break it down a lot more physiologically with different types of receptors and different intracellular processes, but I think it gets a little, I don't know, I get lost in it. And not to say I'm like the best at physiology, but it's complicated, I think. I don't think anyone really fully understands exactly how it works, but that's sort of the gist of high-dose insulin. The lipid bolus, so we talked about this a couple times. What it is, it's basically a 20% fat solution, and it really is used for enteral or parenteral nutrition replacement for people who are NPO or have like hyperemesis gravidarum or have chemotherapy and just are super nauseous all the time. So the product exists for that purpose. It's sterile, but somebody decided at one point that you could actually give this to help people who have had maybe an overdose of certain anesthetic agents. So bupivacaine and ropivacaine, which we use in our epidurals commonly, but also is used for local blocks and to help with different types of surgical procedures. If you happen to have an overdose of that, that can be problematic and can have side effects on its own. So they've used this as a lipid rescue, where they've been doing this in like the surgery and OR type fields for a while. And so this is translated over a little bit, and well, if they can do it for that, why can't we do that for other lipid-soluble drugs? And so what you do is you give a fairly high amount over a quick period of time. What you want to do is make sure all that lipid gets into the bloodstream fast, so it creates sort of this lipid sink, which is going to bind up drug as it circulates through the lipid. Studies are really limited on it, so the question is the data all that good? But we're seeing it more and more as an unknown PEA asystole arrest item. That let's give them lipids. I mean, this again, this person in a PEA or asystole, if you don't know a cause or you don't have an obvious source, the death is highly likely. So, can we throw the kitchen sink at them? Is sort of the theory here. But propranolol. Theoretically, again, TCAs, again, becoming more popular with those because there's really nothing else you can do with them. So that's sort of the theory behind lipid bolus. It's a pretty straightforward mechanism, but it's getting more and more popular in the toxin overdose world. Methanol and ethylene glycol can definitely be really problematic overdose. So methanol is common in windshield washer fluid, and ethylene glycol is common in antifreeze. Interesting side note, apparently depending on where you live in the country, they have different concentrations of these alcohols within, or ethylene glycol or methanol within these products. So like in Minnesota, ours are much higher concentration than you might find in like Florida, which is interesting. So I don't know if different companies make them for different places, but I assume it's maybe cheaper to make it with less. So that's why they do it. And why would you need the same concentration in Florida as you would in Minnesota, right? So that makes sense. But the point is that if you overdose in a northern climate, you're probably going to be consuming more than you would in a southern climate. So what happens? Well, these products both get metabolized fairly similar to how we'd metabolize ethanol. And here's the general processing of methanol in this case. But ethanol dehydrogenates, breaks it down to formaldehyde, which then breaks it down to formic acid. And so that causes metabolic acidosis and tissue injury. And your body can tolerate a bit of this over time, but after a while, it's going to end up with a problematic byproduct that's not going to get metabolized and cause tissue damage. What we can do is a couple things. So fomepizole is a drug called antizol, which inhibits alcohol dehydrogenase. So it actually prevents your body from metabolizing it at all. And methanol by itself is not the best thing. Somebody's going to feel pretty altered on it, like they're drunk to a certain degree. But they're also not going to get that toxic metabolite with the metabolic acidosis and all the follow-up issues with it. You can also put people on dialysis and dialyze off the alcohols too. So they both work pretty similarly, and the drug is really expensive, but it does seem to work quite well. So usually people are on repeat doses, not like a one-time thing. It takes a while for the body to process that. And what happens is you end up inhibiting this enzyme to a degree where your body can get rid of these in a more controlled rate. So you're still going to end up metabolizing it probably to a certain degree, and you're going to get that toxic metabolite, but at least it's not accumulating to such a high degree that it's causing a ton of damage at once. And in the cases I've seen that have been severe with this, I've seen, I think, 2 or 3, they do both. They do dialysis plus they do the fomepizole. So they're dialyzing whatever they can off, but they're also preventing that transformation from one product or from one compound to the other. So it's a combined effort, but certainly very problematic if not treated and highly toxic. But you have to drink a lot of it, so there's that caveat. Other overdoses. Patients may present with a wide variety of symptoms with any type of overdose, so that's why we always like to try and figure out what the ingestion is. If you're ever like, gosh, this person took like 6 different drugs and they're all weird psych meds, I don't know what's going on, that's where poison control comes in handy. There's not a lot of specific treatment algorithms for most of this, and what I talked about were really the common overdoses and also the common popular antidotes that we actually have. But you can overdose on a number of things that have no antidote. But also the nice thing is most drugs you can overdose on and they don't do a whole lot. So again, you always want to rule out acetaminophen and aspirin. Check quick and easy, and it's a pretty straightforward way to at least narrow down what you're working with. But yeah, overdoses can really be all over the spectrum as far as how much they affect somebody and what people are taking. Just finally, Minnesota poisonous plants and animals, in case you're curious. This is stuff I like to Google when I'm bored. So animals, the nice thing about living in our state is there's very few poisonous things that can kill us, if at all, really. You can count some of the snakes in the southern part of the state, might be. But spiders, you might hear about brown recluse bites or black widow bites. Actually, those are not native to Minnesota or the northern climate at all. So if you hear about somebody, oh, my friend's kid got a brown recluse bite, probably wasn't actually a brown recluse bite. People always argue with me on this. I'm like, well, look at the stats. There's only like one reported brown recluse bite that was confirmed in Minnesota in like the last 50 years. So it really does not happen. If it does happen, it probably got there some other way. And we have also biting spiders that have painful bites. So like sack wolf, jumping, and cobweb spiders all can leave pretty nasty bites. Sometimes it can be cause cellulitis, but for the most part, it's not as severe as like a recluse bite. If you ever Googled them, what the actual pictures are real, they're kind of nasty. There is a northern widow, which is sort of a cousin to the black widow, that's less poisonous but can be encountered. So that is possible. It does look similar too. So. Snakes, again, if you don't like snakes, this is a good state to live in. We don't have a lot. We have gardener snakes. That's pretty much it. In the southern river valley, you can have some rattlesnakes and rattlesnake cousins, like I don't know how you say that, Masasaga. I don't know. But anyway, they're very close. They are poisonous. Regional hospitals should have crowfab, which is an anti-venom specifically designed for that. Remove rings, watches, and bracelets. Make sure you're getting blood flow to the area, or not like constricting. So like if you get bitten on your finger and you have a ring on it, make sure it doesn't get swollen and necrotic, so that it can circulate a little bit. Don't suck out the venom. Don't apply ice. Don't cut the bite. None of that stuff has been shown to help. And lightly wrap a constriction band, and that's about it. And then try and get the person to a place where they can administer anti-venom. People can have exotic pets, so you can have like a king cobra bite because somebody somehow imported it and kept it in their house, and whatever. You could get weird stuff like that. Of course, you can't stop humans from being human, but you can generally look at poisonous animals as limited. Plants are another story. We have lots of nasty mushrooms and stuff, but people tend not to eat as many random plants as they do get encounters to weird animals. So, whatever. Plants don't jump out of bushes and attack people, mostly. So. Right? Okay, that's it. Thank you.